Assalamualaikum everyone. We are from HS2623B and today we would like to present our assignment for MRD515 radiographic pathology. The topic of our presentation is colon cancer. So here are our group members, consists of NABILAH binti AHMAD SHAH, NURHAYATIE AZLEENA binti AZMAN, and SITI SALASIAH binti ABDUL HAMIM. In this presentation, we will discuss the overview of colon cancer, including its etiology and complications. We will focus on imaging modalities, radiological appearance, technical considerations, and highlight CT colonography as an appropriate imaging modalities. We hope this presentation will provide a clear understanding of the role of radiographic imaging in the assessment of colon cancer.
What is colon cancer? Colon cancer is a growth of the cell that begins in the part of the large intestines called the colon. The colon is the first and longest part of the large intestines, and the large intestines is the last part of the digestive system to break down food for the body to use. Colon cancer, often known as the colorectal cancer, which refers to both rectal cancer starting in rectum and colon cancer. Conversely, colon cancer refers explicitly to the cancerous growth that develops in the colon and not rectum. However, colon cancer is the third most common cause of cancer-related deaths in US and most prevalent and avoidable type of gastrointestinal cancer overall. According to the Malaysian National Cancer Registry Report 2007 to 2011, colorectal cancer (CRC) is second most common cancer in Malaysia, accounting for a startling 13.5% of all newly diagnosed cases between 2012 and 2016.
What about the etiology or the causes of colon cancer? Most colon cancer are sporadic, around 70%, indicating underlying causes and causal pathways are largely unknown. However, sporadic colon cancer is usually developed slowly through a classical adenoma-carcinoma sequence. The first sequence first starts with accumulation of molecular or genetic defects in colonic epithelial cells. As this defect accumulates over time, it will form adenoma, or also known as adenomatous polyp, which is a precancerous type of polyp, and if left untreated, it will cause carcinogenesis. On the other hand, 3 to 5% of colon cancer are closely related to inherited genetic condition, mostly either related to hereditary polyposis colon cancer, also known as Lynch syndrome, and familial adenomatous polyposis. Other risk factors include people with older age, especially after 50 years old. Family history of colon cancer has also high risk if any biological family member develops disease before age of 45. Next, having adenomatous polyps, inflammatory bowel disease (IBD), and also lifestyle factors such as smoking cigarettes.
Patients' quality of life is greatly impacted by colon cancer complications, which can also impair prognosis by creating new health issues. The first one is the tumor obstruct intestines. There is an abdominal growth tumor in the colon or rectum that block or narrow the passage of the stool. When a tumor obstructs intestines, it can cause severe stomach pain, bloating, nausea, vomiting, and difficulty passing stools. These conditions frequently call for surgery. The second one is the perforation. Perforation is when colon wall rupture and can lead to the intestinal content can seep into abdomen and result in the potentially fatal peritonitis. Next is acute bleeding. Acute bleeding means sudden rapid loss of blood that happens over a short period of time. Acute bleeding can result in the substantial bleeding, whereas prolonged bleeding can cause severe anemia with weakness and exhaustion. Others than that, malnutrition and cachexia also one of the complications that happen to the patient that have the colon cancer. Malnutrition is a state of inadequate intake or absorption of nutrients leading to the impaired body function. Cachexia is a complex metabolic syndrome characterized by severe muscle loss associated with chronic disease. Both can result in the weight loss and muscle, while metastasis to organs like liver or lungs can induce organ failure.
Few common modalities related to colon cancer include colonoscopy, CT colonography, CTC, contrast-enhanced computed tomography, CECT, and also magnetic resonance imaging, MRI. Colonoscopy is not considered as imaging modalities. However, it is briefly included here since colonoscopy is the gold standard of colon cancer, which allows direct visualization and biopsy at the same time. It also allows polypectomy, which reduces progression of more polyps to malignancy. Imaging modalities such as CTC and CECT both uses CT scans. However, CTC uses air or carbon dioxide to distend the colon for polyps and cancer screening, whereas CECT uses contrast agent for comprehensive evaluation of known cancer or recurrence. Although colonoscopy is the primary tool for screening, diagnosis, and treatment, it is invasive and there is risk of perforation and high patient discomfort. Therefore, CTC, also known as virtual colonoscopy, is a diagnostic imaging alternative of colonoscopy, where CTC offers minimal invasive alternative to detect polyps, masses, blood lesions, and overt colorectal cancer, with lower colon perforating risk than colonoscopy. CTC also allows screening for positive stool test patients that are unwilling, unable to undergo colonoscopy, or having incomplete colonoscopy. CTC also has high accuracy of polyps, more or equal to 10 mm, and has smaller threshold for small polyps compared to colonoscopy, which is up to 0.6 mm and 2.2 mm respectively. Nonetheless, the CTC screening still requires biopsy for confirmation. Next imaging is CECT and MRI. CECT of chest and abdomen are commonly used for systemic staging in colon cancer, whereas MRI commonly used to detect liver metastasis. CECT has high sensitivity for detection of tumor invasion beyond the bubble wall T1 to T2 versus T3 to T4. CECT also has fast acquisition, widely available, and has minimal motion artifacts. However, CECT has limited differentiation of T3AB from T3CD to T4 tumors, and also in end staging of colon cancer. There is also limitation of T1 tumor detection due to its low soft tissue contrast. On the other hand, MRI has superior contrast resolution than CT. MRI can also effectively characterize focal liver lesion, and its combination with liver-specific contrast agent can significantly improve accuracy of liver metastasis. MRI with DWI also demonstrate higher sensitivity in staging advanced T3CD and T4 tumors. However, MRI of suspected colon cancer may result in artifacts due to parastasis and colon movement, and MRI also has slower scanning times compared to CT.
Let's move on to the radiological appearance. The first one is the CT colonography. For example, this is a screening CT colonography in a 56-year-old man with a polyps. AZLEENA CTC image demonstrated a classic pedunculated polyps in sigmoid colon characterized by a bulbous soft tissue density had attached to the colonic wall by a thin elongated stalk. Lesion is clearly outlined against the air distended lumen as an approximately 1.5 cm sessile polyp and is distinguished from residual stool by its fixed attachment to a wall and uniform attenuation. Based on morphology and size, this finding would typically be categorized under CRADS system as a significant lesion, as pedunculated polyps are often adenomas that carry a risk of future malignant transformation. Next is a CT scan. CT showing cervical cancer and mucinous colon cancer on CT. On a CT scan, an apple lesion appears as a short segment of bowel wall that becomes thick all the way around, resulting in a narrow and uneven bowel opening. Instead of just showing inside of bowel like a barium enema, CT scan provides a cross-sectional view where cancer appears as a solid mass surrounding colon with raised, inverted edges and ulcerated mucosa ranging from 2 to 6 cm in diameter. CT imaging provides critical diagnostic details beyond lumen, such as pericholic fat stranding, indicating local invasion, presence of enlarged region lymph nodes, and potential for distant metastasis to organ like the liver, making it primary tool for clinical staging. Meanwhile, if MRI reported a tumor with an outgrowth from colonic wall of 7 mm. Radiological appearance of colonic wall on MRI is primarily assessed by evaluated mural thickness, symmetry, and layering. Abnormalities are characterized by wall thickening where a halo sign visible layer of edema often suggests inflammatory condition like colitis, whereas asymmetric short segment thickening with the abrupt shouldering edges and loss of normal layer architecture is more indicative of malignancy. Radiologists look for extramural extension where wall's outer border becomes blurred or shaggy, suggesting that an inflammatory or cancerous process is growing in surrounding pericolonic fats.
Next, I will discuss the technical considerations applied in CT colonography. CT colonography is performed after adequate bowel preparation and rectal insufflation of gas, most commonly carbon dioxide. This step is important to ensure proper colonic distension, which allow clear visualization of the colonic wall and lumen. To differentiate true lesions from residual stool, images are required in at least two positions, typically supine and prone, with lateral positioning used when necessary. Moreover, thin slice image acquisition is employed to improve spatial resolution and enhance lesion detection. Furthermore, recent studies have demonstrated that reducing the tube voltage to approximately 100 kV significantly lowers radiation dose without compromising diagnostic image quality, therefore improving patients' safety. I will now explain about the appropriate imaging modalities for colon cancer, namely CT colonography. CT colonography is a crucial imaging tool with several advantages over conventional colonoscopy. It provides a safe, direct visualization alternative for patients who have medical conditions that increase the risk of sedation, bleeding, or perforation. Studies have shown that CT colonography has high specificity and sensitivity to detect larger polyps. It allows complete evaluation of the entire colon, even in cases where colonoscopy may be incomplete due to strictures or patient discomfort. Additionally, CT colonography provides valuable information about the local extent of the tumor and can detect extracolonic abnormalities which colonoscopy cannot. However, its accuracy depends on the cancer stage and the presence of lymph node metastases, and it is less effective in detecting early colorectal cancer. One limitation is that flat lesions may be missed, as thickened folds, incomplete bowel distension, or residual stool can mimic polyps. Therefore, although conventional colonoscopy remains the gold standard for diagnosis and treatment, CT colonography is a valuable alternative, especially when colonoscopy is contraindicated. Did you know, as I've mentioned before, CTC has high sensitivity and specificity, which are 91% and 93% respectively for polyps more than 6 mm, and 92% and 98% respectively for polyps more than 10 mm. In conclusion, colon cancer is a common malignancy that can lead to serious complications if left untreated. Accurate diagnosis and effective treatment require appropriate imaging selection, proper technical consideration, and recognition of characteristic radiological appearance. Although colonoscopy is considered as the gold standard, CT colonography offers a safer, less invasive, and highly effective alternative for detection and staging of the colon cancer, particularly for patients at risk from sedation or invasive procedures, making it a preferred choice in many clinical situations.